So yeah, Festival of Learning. I see a few of you coming in on this. I hope you guys have been to some of the other bits and pieces going on. I was just telling Liz, it's a great idea. Are you all professionals, or are some of you like members of the public who are like interested in and just come along because it's an interesting subject?
I'm a childminder.
Okay.
I'm a neighborhood development officer for Chandler Borough Council.
Okay. I mean, I guess in pretty much any profession or where you're dealing with members of the public, with families, you're going to encounter perhaps drug or alcohol use. So it's a worthwhile topic going into. What we're going to do today, we've only got an hour and a half, which is nowhere nearly enough time to go as deep into this subject as is possible to go. You know, people spend their careers doing drugs and alcohol, and we're going to try and chip into it in an hour and a half. So it's a kind of necessarily we'll have to miss a lot. And like I say, you can always go deeper, but I'm going to give you an overview today of the most common drugs that are out there, and we're going to be talking about alcohol. We're going to spend a disproportionately large time on alcohol, probably about half the session. And that is because you're more likely to encounter people who have an alcohol problem than a drug problem. And the reason for that is it's legal and it's common. And we live in a society, in a culture where alcohol is everywhere. You know, it's cheap, it's in the shops, it's on TV, it's how we celebrate, it's how we commiserate. So in that kind of environment, it's very easy for people to drink perhaps more than is good for them, which isn't a lot of alcohol, as we shall discover. Okay. Before we get started, I'll just tell you a bit about myself. My name's Drew. I work for Turning Point, which is the commissioned drug and alcohol service in Leicester, Leicestershire, Rutland. This training thing for me is a bit of a sideline. My day job is I'm part of the UHL hospital liaison team. So I'm based mainly in the accident and emergency department of the Leicester Royal Infirmary, and my job there is to take patients who might have a drug or alcohol problem. Maybe that's why they're in hospital: drug overdoses, withdrawal, liver damage due to drinking too much, all kinds of things like that. My job is to go and talk to these people, have a bit of an intervention, and then if they want ongoing help, my job is to plug them into all the support available at Turning Point. I'll talk about what that support actually is toward the end of this session. Okay, well, let's kind of get into it. So when you're talking about drug use, and that covers alcohol as well. I think it's important to say that alcohol is a drug. It is a chemical that when you put it into your body, it changes how you feel. Therefore, it is a drug. Okay, just because it's legal doesn't mean it's not a drug. Same goes for tobacco. We're not going to talk about smoking in this session. There's a whole other session about smoking and quitting. Okay, but when it comes to drug and alcohol use, there's three kinds of drug use, I would say. The first kind is like recreational use, and this is like where people always start. Often young people in their teenagers or 20s, that's kind of when people start experimenting with these things, and there's a lot of peer pressure involved. It's like weekend use or binging at the weekends, or people just experimenting, like, I wonder what it's like to try this, to try that. It's kind of like the lowest level of drug use. Not that it doesn't come without dangers, it certainly does, because, you know, there's recreational use, if you don't know what you're doing, can lead to overdoses. Binges do come with all the sorts of problems associated with that. Hangovers, getting into fights, some waking up in hospital sometimes. Put yourself in a vulnerable position where you can have your advantage taken of you. So recreational use is certainly not without its risks. But the more you use something, the more often you use it, you're flirting with addiction. Okay, so addiction is a chronic condition whereby if you keep doing something that is pleasurable for you, at some point your choice is taken out of the equation. It stops becoming a decision-making process, shall I or shan't I? It becomes compulsive. And at that point, it's what we call pathological, which means it's a disease. So at that point, you have the disease of addiction, and it is not straightforward to overcome that. talk a bit more about addiction in a slide or two. The further form of drug and alcohol use is dependence. So you can think of dependence as like the physical version of addiction. So addiction is psychological. You feel like you need the thing psychologically. Dependence is when your body physically needs the thing. Okay, you take so much of the drug or the alcohol that your body starts to expect it, and then if you deprive your body of that alcohol, for example, then you actually go into withdrawal. Okay, so they're kind of the three kinds of drug use. Not all drugs are addictive. For example, a lot of the hallucinogens, which we're not, like LSD, things like that, which we're not really going to talk about today, which is a shame because it's probably the most interesting kind of drug. But people tend not to have serious problems with it because it's not addictive, doesn't form addictions. But things like stimulants, cocaine, alcohol, smoking, tobacco, heroin, all these things are addictive. Because of the intense feeling of well-being in the short term they cause when you put these things into your body. Not all addictive drugs cause dependence. Okay, so like cocaine, for example, you can be addicted to cocaine, having it every day, but if you stop suddenly, psychologically you will crave it, but your body won't miss it, your body won't withdraw. Okay, so only certain drugs cause dependence. The big two are alcohol and your opioids, anything that comes from the opium poppy, which includes heroin. Okay, so if you're drinking heavily or if you're taking heroin every day, if you stop suddenly, you will go into withdrawal, and that can be problematic. We'll talk more about withdrawal when we come to to those bits in the presentation. Okay. I mean, if you've got a dependence, if your body physically needs the thing, chances are you're addicted to it as well. You kind of naturally pick up an addiction on the road to dependence. So if you're trying to help someone in that situation, you've got two problems. One is weaning them off the physical dependence, and the other problem is helping them overcome the cravings of addiction. Okay, so it's kind of doubly hard. I mean, when people are addicted, people with addictions face an awful lot of stigma. Like if people are like alcohol dependent, there's a lot of stigma against them, and people say, why don't you just stop? You've brought it on yourself. You're putting this in your body. Just stop. And it's not that easy. Like I just said, addiction is pathological. It is an illness, and therefore people with addictions need to be treated with the same level of respect and empathy and understanding and non-judgmentalism as anybody else with any other kind of disease. Okay, because they face huge barriers to treatment because of their assumption that they're not going to be listened to, or that they're going to be told it's their own fault. Sometimes people who should know better are guilty of this. GPs, the police. I think sometimes there needs to be some education with people like that to be a bit more empathetic and understanding with people with addictions. So it's not easy. It's not as easy as stopping. It takes more than just willpower. The way to overcome an addiction, excuse me, is to kind of learn new habits. It's to, in a sense, to become addicted to more positive things. Like if you're drinking because you're stressed, well, can you find a healthier way of dealing with stress that isn't alcohol? And the more you do that thing, after a certain while, that becomes the habit, that becomes the compulsion. Okay, so it's not easy. It's not something you do overnight, but that's kind of like how you overcome an addiction. Okay, so that's just a bit about addiction and dependence. Let's turn our attention now to alcohol. Let's first half of this is going to be all about alcohol, like I said, because it is so prevalent. So let's get down to this. It's worth mentioning COVID, because what we have seen since the start of the pandemic, we have seen people develop new alcohol problems because of the pandemic. Why? Because people, the start of the lockdown, people were isolated, people were bored, they couldn't go out and do their hobbies, they couldn't get out and socialize. People's stress level went up. Now, how do people cope with those things? Alcohol. This is the trap with alcohol. If you're feeling stressed, if you're feeling anxious, if you're feeling bored, if you're feeling lonely, have a drink. It all goes away for a time in the short term. And so people were turning to alcohol to cope with the pandemic. Pubs and restaurants were closed, so rather than people going out drinking there, people drank at home. They bought their alcohol from the supermarket. You buy alcohol from supermarket, it's cheaper. The cheaper it is, the more you buy, the more you buy, the more you drink. Okay, so we've seen people develop alcohol dependencies since the start of the pandemic because of the pandemic. Not really going to talk about this as somebody else's presentation, but domestic violence for the same reasons, like that pressure cooker of families confined. You pour alcohol on a situation like that, incidents of domestic violence go up as well. In the early days of the pandemic, not so much anymore, but support groups like AA had to close because of social distancing. And so people who had alcohol problems suddenly couldn't access those support networks that they were relying on, and that sort of exacerbated their drink problems. I have to say with Turning Point, which prior to COVID was kind of like a face-to-face group work program, we kind of very quickly switched over to telephone work, which seemed to work really well. And in fact, when you're doing telephone work with people, you can reach more people. People with drink problems tend to have anxieties, sometimes about leaving the house, getting on a bus, let alone sitting in a room full of strangers talking about yourself. So people wouldn't engage with Turning Point, but if it's over the phone, actually we're reaching a lot more people. So it kind of has had a silver lining, the pandemic. Not so much drugs. So since the start of the lockdown, what we noticed is that kind of the lockdown kind of applied to drug dealers as well. So we saw sort of like a kind of dip in drug supplies, which net is picking up again now. But at the start of the pandemic, drug use kind of stayed the same, but alcohol use went up. Alcohol use more generally, here's some statistics about how kind of bad the situation is. 40% of adults in England are drinking at levels which pose some risk to their health. I don't know how many adults there are in England, several tens of millions, I would guess. So 40% of that is still tens of millions. They're drinking at levels which pose some risk to their health. And we'll talk about what that level actually is in a slide or two. An estimated 600,000 adults in England are physically dependent on alcohol. So they're drinking enough that they will withdraw if they stop suddenly. Alcohol has been identified as a causal factor in more than 200 medical conditions. It used to be 60, but I think that they did some bit of research and it shot up to 200. So when you're drinking alcohol, it gets in your bloodstream. It travels to every cell of your body. So there is no part of your body that can't be negatively impacted by drinking too much. Okay, things you might not associate with drinking too much, things like breast cancer, for example. If you're drinking too much, it increases the risk of you getting breast cancer. Obviously, we're not going to cover all 200 of these medical conditions today, but we'll scrape a couple of them. There are over 1 million alcohol-related hospital admissions every year. Now, like I said, I work in the emergency department of the Royal Infirmary, and if you ask any doctor or nurse there, how many people a week do you see in hospital because they've had too much to drink? And they'll roll their eyes and say too many. So the reason I work in the Royal Infirmary is if we can help people with those addictions and help them sort those problems out, then perhaps in the long run we can reduce hospital admissions. Okay, if people did take more control over what they were drinking, addictions and dependencies aside, then it relieves a bit of a burden on the NHS. Okay. Alcohol accounts for over a third cases of all liver disease. Bringing it a bit closer to home, in Leicestershire, Rutland, there are an estimated, give or take, 10,000 dependent drinkers. So again, that's people who will withdraw if they stop suddenly. And I can tell you not nearly all of those people are in treatment for their problem. Okay. In fact, only a small sliver of those people are actually getting help for it. These stats are a couple of years old, as they always are with like drug and alcohol figures. It takes a couple of years for them to crunch the numbers. It's probably due for an update on that now. Okay, so if you do drink too much, here are some of the things that can go wrong physically. Some of those 200 things: cancers, liver disease, pancreatitis, depression, stomach problems, brain damage, diabetes, all sorts of nasty stuff. Just looking here, we'll touch on a couple of them. So that's what can happen if you drink too much. So how much is too much? It's all about units. You've probably heard of units of alcohol. Units are a great way of working out how much actual alcohol you're drinking regardless of what kind of drink it is you're drinking. All right. So if you're drinking rum or whiskey or wine or cider, whatever it is you're drinking, if you know the units, you know the alcohol. Because if you have an alcohol problem, you don't have a wine problem or a beer problem. You have a problem with the alcohol in those drinks. Okay. So units are a great way of working out how much actual alcohol somebody's drinking. Now, the current advice is not to have more than 14 units per week spread throughout the week. This is advice from the Chief Medical Officer, who is Chris Whitty, that guy we see on telly talking about COVID. His advice is 14 units per week spread throughout the week. So you can't have all your 14 units on a Friday night, because that's a binge. Nor can you say, well, 14 units a week, that's 2 a day. No, because you're supposed to have some days off as well. So it's a bit of a mouthful. 14 units per week spread throughout the week with some days off. Now, that's not a safe amount of alcohol. The only safe amount of alcohol is 0. 14 units per week is the low risk amount. Okay, they didn't want to say, listen, don't drink at all. Got to put that that guideline in there somewhere. So 14 units per week is like the low risk end. Binge drinking is when you have 8+ units in a session. And it stands to reason the further beyond 14 units per week you drink, the worse the problems will get. Okay, especially beyond the threshold of dependence. I keep talking about dependence. So this is at the point where your body starts to make changes to adapt to all the alcohol coming in, and then you withdraw without it. Now, everybody's different. It depends on your age, your sex, your BMI, your metabolism. Everybody's different, but give or take, if you're drinking 10+ units a day, or you could say if you're drinking the weekly recommended amount, but every day, that's kind of the level at which you start to get dependent. All right. But what is a unit? What does it look like? So 1 unit of alcohol is 10 mils of like pure ethanol alcohol. Ethanol is the kind of alcohol we drink. There are other kinds like methanol, which you get in methylated spirits. Don't drink that. Ethanol is what we drink. So 10 mils of that, pure that, is 1 unit. And that's going to be diluted in different amounts in different drinks. So the most concentrated is going to be your spirits, whiskey, rum, gin, all that kind of stuff, give or take 40%. Be more diluted still in wines, more diluted in ciders and beers. Like that. You can see in this graphic here, that's kind of like what 1 unit looks like in various drinks. So give or take half a pint. A small glass of wine, and it's a very small glass of wine. You can get really tiny glasses. It's one of them. Probably half of that is 1 unit. Spirits are easy because it's 1 pub measure, which is 25 mils, is going to be 1 unit. There is a formula to work it out. I don't suggest you do that in your head. Here's how I remember it. This is how I work out units. You can say 1 liter of any drink is going to have in it the same number of units as the percentage strength of alcohol. Okay, so you get a drink, it's going to have a number on it, how percentage alcohol by volume. So you can say, well, a pint of whiskey's 40%. Sorry, a liter of whiskey. Whiskey is 40%, so there's going to be 40 units in that liter. People drink pints. A pint is, give or take, half a liter. So you can say a pint of Strongbow at 5% is going to be half of 5, 2.5 units. Okay, so that's how I work it out. People drink cans, so that's going to be about 500 mils. So you just halve the percentage strength. So if someone's drinking a can of 4%, it's going to be 2 units. That way, if someone says I'm drinking eight cans of Carling a day, you can say, well, that's 8 times 2, 16 units a day, which already is more than the weekly recommended amount. Because if you suspect somebody's drinking too much, and they're experiencing some of the problems that go along with such a high intake, it helps to put a number on it. You work out how much they're drinking per day and compare that to the weekly recommended amount, and then you can tie it in and reflect that back to the person and say, listen, you're depressed, you're not eating, you got liver problems, you've lost your job, blah 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 blah, and you're drinking 20 units a day. Coincidence? I mean, maybe I'm saying this because I'm an alcohol counsellor, but these are the kind of people I work with. But to me, often somebody sorting out their drinking is the key to everything. Somebody sorts out their drinking, their mental health gets better, their physical health gets better, their relationships get better, their money gets better, their legal trip, blah, blah, blah. Everything gets better if you sort the drinking out. The problem is, the trap is, people use alcohol to cope with life, and you know, what you're asking them to do is find better ways of coping, but that has better dividends down the line. Okay, right, let's talk about dependence more. We talked about dependence, so this is really important. If somebody is drinking heavily, do not tell them to stop drinking, right? Because it can be very, very dangerous. Alcohol withdrawals can kill you. Not a lot of people know that, including people who are drinking at that level. So people drinking a bottle and a half of vodka a day, wake up one morning and think, right, I've had enough, I'm going to quit. That evening, they're in A&E, having had a withdrawal seizure, okay? So it kind of like puts people between a rock and a hard place. They're drinking too much, they need to cut down, but they can't do it suddenly because it can be really dangerous. Have a look at this thing on screen right now. This is a kind of chart. Alcohol withdrawals it's like a spectrum. You can get mild withdrawals, more serious withdrawals, and then really dangerous withdrawals. And they get worse the more dependent you are. So on the right-hand side of this chart, you can see it's like units per day. And like I say, everybody's different, so it's really rough. But give or take, starting at 10 units per day and going up, the worse these things get. So the most common withdrawal symptoms might be sweating at night time, like hot and cold flushes, waking up in the morning and your hands are a bit shaky. These things tend to be worse first thing in the morning, because if somebody's been asleep, they've not been drinking while they've been asleep, although some people do sleep with a can by the side of the bed. But if people haven't been drinking because they've been asleep, it stands to reason that they'd be withdrawing more first thing in the morning. Anxiety, tachycardia, that means your heart's racing. More serious still, the more dependent you are, nausea. People can like vomit in the morning, or if their stomachs are empty, it's just heaving. Hallucinations, now that can be like auditory or visual hallucinations. It can be like sounds of people in the next room, or black shapes in the side of your vision. So really serious hallucinations, like people saying, my long dead grandmother just walked into the room and started having a conversation with me. Really vivid hallucinations. Then it starts to get into medical emergency country, okay? So stopping drinking suddenly can cause seizures. Seizures are not good. If people live alone, they won't actually realize they've had a seizure. You don't remember having a seizure, but people might stop drinking or reduce too quickly and then wake up on the floor, bruised and battered. They might have had a seizure. Then there's this thing called the delirium tremens, the DTs. This is quite a misunderstood thing. People shake and say, oh, I've got the DTs. That's not the DTs, that's just a tremor. The DTs is a full-blown psychotic / delirious episode whereby you won't know what's going on, you won't have capacity, you'll be hallucinating, you'll be agitated, your temperature will be through the roof, your heart rate will be through the roof. It's a medical emergency because it actually kills something like 1 in 5 people who get it. Okay, so it's a medical emergency, and they need to be in hospital for that, like ASAP. Then alcohol withdrawal can put you in a coma and it can kill you. All right, so really important that people are aware of that. I mean, often like loved ones of people who are drinking too much need to know this, because it might be they throw down an ultimatum like, you need to stop drinking today or I'm leaving. They can't stop straight away because it can kill them. All right, so there's a lot of room for education out there. All right, so what do you do if this applies to you? You don't want these withdrawals. How'd you get off it? Well, here's how you get off it. You need to wean off it. You need to wean off it slowly and sensibly. That's what you need to do. Okay, so stabilize and reduce. This is how you do it safely. So the first part of this is to stabilize. So what you'll find is a lot of people who are dependent drinkers are actually chaotic dependent drinkers. So yes, they'll get withdrawals, but actually their drinking is up and down day to day. Like one day they'll drink a litre of whiskey, and then the next 2 bottles of wine, and then the next 8 cans of special brew, blah, blah, blah. So the first job is to stabilize it. So this is about finding an amount of alcohol that keeps people steady for 24 hours, keeps them ticking over. Not so much that they're drunk, not too little that they're sweating and shaking, just enough to keep someone ticking over, right? And you put a unit number on that. That is X. I am dependent at X units per day, okay? Really helpful knowing the units. And then what you do, once you've stabilized, you can cut it down every couple of days by, say, 2 units. Another way of doing it is 10%. You can reduce by 10% every 2 or 3 days. Another way of doing it still is to say only drink when you feel yourself withdrawing. And then it should settle down, then wait, and then later on you start withdrawing again, you have another. So then you're always drinking at the bottom level of your dependence. And then as the days go on, you'll find that level actually gets less and less. And as you do this, which is easier said than done, but this is the textbook way of doing it. As you do that, as the days go on, you'll notice some of these withdrawal symptoms starting to get better. Like, I'm not feeling quite so sick today. I'm not feeling quite so shaky today. It gets better as it goes on. If you can get down to comfortably under 10 units a day, you're probably out of danger from some of the riskiest stuff. So if you can get it down to under 10 units a day, you can have a go at stopping if you think you can, or having days off. What we do say to people trying to do this is eat little but often, because coming off alcohol plays havoc with your blood sugar levels. So it's important that you're eating while you're doing this. That's the best way of doing it, because like I said, this is beating the physical dependence. This doesn't do anything for addiction. So the psychology of thinking, I need a drink, you have to do that work if this is going to succeed. But if people do put their mind to this, they have to learn those coping skills as they go along, which is great, because that'll help prevent a relapse in the future. So like treating addiction in a nutshell, I kind of touched on this earlier. People will have triggers, reasons for drinking, or excuses. And the number one I hear is boredom. Oh, I drink because I'm bored. Okay, I drink because I'm stressed, depressed, lonely, bereaved, I can't get to sleep, that kind of thing. And that's the trap with alcohol. While it's going down, it does take those feelings away. Although the more you drink, actually, it starts feeding into those very problems. Things like depression and sleeplessness. If you're a heavy drinker, you're going to be depressed and you're not going to be sleeping right. So you can be in a vicious circle then. But addiction treatment in a nutshell is about helping people identify what their common triggers are, and then coming up with strategies to cope with those triggers. So, and it's not rocket science. If you're bored, you need something fulfilling to get your teeth into. You need a reason to get up in the morning, and that's going to be different for every person. You need a hobby, you need an interest, you need a job, you need something. Because if you just stop drinking, or if you reduce down, but you're still bored, you're still twiddling your thumbs, you're more likely to relapse. You're more likely to slip back into it, because that's the only way you've got of coping. You need other ways of coping with these triggers. Okay, so you have to do this work if the reduction is going to succeed. There is another way to overcome physical dependence on alcohol, and that's through a detox. So a detox is like a medical procedure. We can do them. Turning Point use a purpose-built detox facility up in Nottingham, which kind of does the wraparound addiction stuff at the same time. But that's like medicated. You go into detox for like 7 days, 10 days, and they give you diazepam, which is a part of the benzodiazepine family of drugs, which we'll talk about later, actually, because these are addictive. You start on 10 of these a day, and then on day 2 it's 9, and then 8. So they wean you off over the course of a week, which is exactly the same as if you were at home cutting down your alcohol. Okay, so that's a detox, which Turning Point can arrange. But detoxes fail. People relapse afterwards if they don't do this work about their triggers and learning to cope with life without that thing that they're addicted to. Okay. All right, so let's talk more about some of those physical consequences of drinking too much. And like I say, in an hour-and-a-half session, there are many of these I could do, but we'll only just do a couple of them. Let's talk about livers. So you ask anybody on the street, oh, if you drink too much, what can go wrong? Chances are they'll say, oh, that's no good for your liver. Correct. So it's your liver's job. Your liver's a big thing that sits on the right side of your lower rib cage. One of the biggest organs in the body. It does like 500 different things, one of which is to metabolize any alcohol that you drink. And it's very good at doing that. It can do it at a rate of about 1 unit per hour. So you can immediately see if someone's drinking more than 24 units a day, your liver is continuously processing alcohol. It never has a break. And if your liver doesn't get a chance to heal itself, your liver's very good at repairing itself. Your liver gets a little bit damaged every time it processes a bit of alcohol, okay? And your liver is very good at repairing that damage if it gets the chance. If it doesn't, if the alcohol just keeps coming, some of this damage can build up. Okay. And the first stage of sort of liver damage through alcohol is fatty liver. You see in the top right of the screen here. So fatty liver is what it sounds like. Your liver is surrounded by and infiltrated with fat. Now you can imagine if you've got that, it really interferes with the day-to-day process of your liver. Like blood should flow around your liver quite freely, so it can all be processed. But if there's fat blocking up all the little ducts and holes and blood vessels, then it really has an impact on what the liver can do. With fatty liver though, it's not permanent, it's not irreversible. Like, you know, if we've got fat on our bodies, if we really start looking after ourselves and you know, take care of ourselves, we can lose fat. So the same thing goes for fatty liver. If you turn things around and look after yourself, you can recover from that and go back to a healthy liver. At some point though, the next stage on from fatty liver is this, down in the bottom left is cirrhosis, which you might have heard of. So cirrhosis is when your liver starts scarring up. Okay, so some of this damage, it can't be repaired with liver tissue, it gets repaired with scar tissue, i.e. tissue that doesn't do the job of a liver anymore. Now we've all got scars on our bodies somewhere, haven't we? Once you've got them, they don't go away. So if you've got a scarred liver, you will forever have a scarred liver. But it's about stopping that scarring growing, because you know, you can have a bit of scarring on your liver, a lot of scarring, and then an extreme amount of scarring. And as that process goes on, I think it's like a fuse burning down on a bomb. You know, you can stop the fuse, but you can't regrow the fuse. But if you keep the fuse burning, at some point the bomb goes off. So if you've got cirrhosis, at some point you hit a tipping point where it gives up and you're looking at organ failure. There are two wards in the Leicester Royal Infirmary, the gastro wards 42 and 43, which is full of people who've got cirrhosis of the liver, and you're talking things like jaundice, swelling of the abdomen, vomiting blood. These are some of the side effects of having cirrhosis of the liver. If this were a longer session, I'd go into some of that with you, but it has a huge knock-on effect. And with cirrhosis, it's some people who have cirrhosis, the only advice can be you need to stop drinking altogether. Forget 14 units per week, you need to be on 0 units per week. Because people who have cirrhosis, something like 90% of those people, it's the thing that ends up killing them in the end. But it's certainly true if you've got, you know, mild to moderate cirrhosis, if you really start looking after yourself, you can still live a perfectly healthy life. Okay. On from cirrhosis, relatively rare, but if you do have cirrhosis, it's a huge risk factor for it, is liver cancer. So at that point, you're looking at a transplant or nothing. It's kind of like game over. You know, there aren't shelves of livers waiting to be transplanted in people. A lot of luck is involved, and they won't give you a transplant if you're still drinking. So you really need to be on top of things and really motivated and be lucky if you get a liver transplant if you've got liver cancer. Okay. So that's livers. Changing the subject now, this is another consequence of drinking too much, right? Here is something really common that you've probably never heard of. I want to talk about this, Wernicke's-Korsakoff syndrome. I want to talk about it because it's really common. GPs and hospitals will know that this is a common thing, people drinking too much, and I want you to know about it too, okay? So how can I explain this? Right. Drinking alcohol negatively affects your appetite. The more you drink, the less you eat. And that is because there's a lot of sugar in alcohol, and all this sugar hits your stomach and tricks you into thinking that you've eaten. So I certainly work with people heavy drinkers who haven't eaten in days, right? And they've lost weight, and they're not getting any nutrition. And that's the problem. If you're not eating, we're all made of the food we eat, aren't we? So it stands to reason if we're not eating, things are going to start going wrong. Things are going to start dropping off us. If you're not eating, you're not getting vitamins, protein, minerals, fiber, all that kind of stuff. Medically, the one we worry about is vitamin deficiency. Vitamin B in particular, also known as thiamine. Thiamine, vitamin B1, is what your brain and your nervous system need to function properly. It's like the grease that makes it all go, okay? So really common, drinking too much, not eating, you get a thiamine deficiency. And these are the kind of symptoms that you can expect. And if you think, well, this is a problem with your nerves and your brain, these symptoms kind of make sense with that. Ataxia, that means clumsiness, sort of a lack of coordination, not being able to balance properly, which looks a bit like being drunk. So that's kind of like alcohol as well. Memory loss, confusion, people not being oriented. So what I'll say when I meet someone in the hospital who's perhaps drinking too much, I'll say, not a trick question. Can you tell me today's date? And can you tell me where we are right now? When it's obvious we're in a hospital ward. And they might say to me, what a stupid question. Yes, it's 3rd of January 1983 and we're in my front room. What are you doing in my house? And they'll say it with a straight face because their brain just isn't kind of making the connection. It's a thiamine deficiency because they're not eating, because they're drinking. Okay. Vision problems, flickering of the eyes, double vision, hallucination, confabulation, which is when your brain kind of makes up fantastic stories on the fly just to fill in the blanks, the gaps in your memory. Okay. Now, if you see anybody with these symptoms and it's kind of tying in with what you suspect their alcohol use is, again, units per week, and if they're not eating, you need to think, it could be this thing, the thiamine deficiency. Now, all that is the Wernicke's side of Wernicke's-Korsakoff's. The reason it's so important that you guys are aware of this is because if you don't catch it, if you leave it, then it flips over into Korsakoff's. Now, Korsakoff's is all this, but it's permanent. You've passed the point of no return, and you're talking like actual brain damage. And at that point, you're talking like it's like alcoholic dementia. You can think of it as. So people with Korsakoff's syndrome, which you might have heard of, is a bit better known than Wernicke's. Korsakoff syndrome is permanent, and you're thinking these people will forever struggle with forming new memories. They will forever be disoriented, and really at that point you're looking at residential care is the only kind of treatment option for those people. So you need to be aware of this to stop it getting that far, because you can treat it. All those symptoms I listed there are the Wernicke's side of it. Now, the treatment is, it's a thiamine deficiency, it's a vitamin B deficiency. So the treatment is with vitamin B. Now, and we hand this stuff out. If you go to your GP and say, doctor, I think I've got a drink problem, one of the things they will do automatically is prescribe you strong prescription strength vitamin B. Okay. The other thing they should do is refer you to Turning Point, which they don't always do. But anybody who comes into the hospital as an inpatient and alcohol is a factor, they will automatically be given high doses of vitamins, okay, to turn things around. People do sort of literally come out of it if you fill someone with these vitamins, okay? And that's to stop it reaching this tipping point into irreversible brain damage. Okay, so if you guys are working with anybody who's drinking too much, is a bit confused, pins and needles are really probably the most common symptom. Actually, is people getting pins and needles in their fingers and toes, and they're heavy drinkers. It's this again. Okay, so if you see anybody that this might apply to, they ultimately, if they cut their drinking down, their appetite will go up, and then really you should be getting all the vitamins you need from the food you're eating. But in the short term, you can't overdo it with thiamine. You can take huge doses because your body just takes what it needs and you pee the rest out. Okay. All right, so we kind of jumped around the place. There is much more to say about alcohol, but not in a 90-minute session. Okay, so that's kind of it for alcohol. How many people? Any questions? This isn't a terribly interactive presentation, and I do talk very quickly, but if any of you do have any questions, just put your hand up, shout out. If there's no questions, we'll go on to drugs. How are we doing for time? Not too bad. I do talk quick, so it is possible that this session might take less than an hour and a half, but we'll see. Okay, so that's alcohol. Which, like I say, you're much more likely to encounter someone with an alcohol problem than a drug problem, but drugs are certainly out there. Okay, so what we're going to cover for the next half, I'm just looking ahead, seeing if I've covered it. Yeah, we're going to cover some of the more prevalent drugs that are out there in Leicester. There are many other drugs that we're perhaps not going to talk about, which I don't really have much to say about ketamine or nitrous oxide, those little cream canisters you get. More of a litter problem than a drug problem, if you ask me. But if you do have any questions about any drugs we don't mention, then Fire away. But let's start with the big one. Let's start with heroin, because I know maybe working in Turning Point, it just seems to be a huge problem because these are the people we see every day. But heroin is certainly a problem out on the streets of Leicester, Leicestershire. So heroin, what is it? Well, originally it's a medicine. It's a drug that is used in hospitals. It's about, I don't know, 120 plus years old. Heroin. It's an opioid, which means it's derived from the opium poppy. The chemical name for heroin is diamorphine, or acetyldiamorphine, and it is still used, I think, post-operatively. Like if you're coming around from an operation, they do still give diamorphine to people, and used in that context, it's actually a very safe, effective drug. If it's given to you properly by an anesthesiologist who knows what they're doing, it's no problem. And what it takes pain away, and it along with that. I've never tried heroin, but I have tried morphine, and it's in the post-operative context. I had an operation on my back a few years ago. Coming around for it, they gave me morphine. Diamorphine metabolizes into morphine in your system, so if you have heroin, it becomes morphine. And it's a very relaxing euphoria that it kind of gives you. I've heard it described as it's like being hugged by a big blanket of love and warmth and carelessness. So I get it. There's a lot of euphoria involved in that, and this is where the addiction lies. Anything that is addictive gives you something like that, whether it's relaxation or with the stimulants, a sense of confidence. Things that are addictive may give you something really intense, and that's why this stuff is addictive. This is how people get hooked on it. It is also a bit like alcohol, dependence forming. So that is, if you get, the more you take, your tolerance goes up. The more your tolerance goes up, the more your dependence goes up, and the worse the withdrawal symptoms get when you come off it. So heroin is one of these drugs that you can get dependent on. But we'll talk more about withdrawal in a slide or two. There are 1,000 different names for heroin, how it's referred to, but in Leicester it tends to be called brown, gear, smack. These are kind of the terms that are on the street at the moment. It's probably most commonly injected, although you can smoke it. We recommend people smoke it because it's less bad for you. The idea is if you inject it, it goes straight into your bloodstream, so it avoids all the filters of your lungs, which the idea is, well, that sort of takes some of it away. If you're putting it straight into your veins, you get a bigger hit. But if you're injecting, certain risks come along with that. You can do damage to your veins, and indeed people end up having to have their legs amputated from injecting too much. There's a whole ward at the Glenfield Hospital, Ward 23, the vascular ward. That's where people go to have their legs amputated because they've damaged their veins and arteries from injecting. That happens quite often. People are at a greater risk of getting blood-borne viruses like hepatitis, HIV, and that's if people are sharing the needles, sharing the spoons. Viruses can get passed around that way. People can get DVTs or blood clots or pulmonary embolisms or heart infection. Injecting can cause all this kind of stuff. You're also at a greater risk of overdose, which we'll talk about in a little while. So we actually encourage people to smoke rather than inject. Having said that, Turning Point employ a harm reduction approach. So this is an approach to, there's two schools of thought around drug treatment. One is the abstinence model, which like AA and NA kind of preach. So you need to get off it entirely. You need to abstain absolutely. The other school of thought, what Turning Point practices, is the harm reduction approach, which is to say people are going to use drugs no matter what we say, no matter what the law says. People are going to do it. So how can they do it as safely as possible? How can we help to keep them alive long enough to that point where they are ready to quit? And to that end, what we do is we have a needle exchange. So we hand out needles. We hand out all the kits that people need to inject drugs as safely as possible, okay? Because we don't want people reusing the same needle again and again. We don't want people passing it around. So by giving them clean stuff they need to do that, it's actually reducing the harm that comes to them, okay? up until that point where they're ready to do. Statistically, needle exchange programs absolutely reduce the prevalence of HIV and some of these other scary things as well. Okay, that's injecting. So opioid withdrawal. So like I say, heroin is dependence forming. That is, you withdraw if you don't take it, but it's very different from alcohol. The reason it's different from alcohol is because they work on different neuroreceptors. Different drugs work on different parts of your brain. So you get drugs that act on your opioid receptors. You get drugs that act on your cannabinoid receptors, on your serotonin receptors, and not all of them are addictive, but the ones that act on your opioid receptors are alcohol, and we'll talk about the benzodiazepines later. They work on your GABA receptors and they're dependence forming as well. So because it's a different part of your brain, actually the withdrawal profile, the symptoms are different. And actually when it comes to opioid withdrawal, unlike alcohol, it's not dangerous. It won't kill you. So you can say, listen, if you want to go cold turkey from heroin, you're actually safe to do so, although it is extremely uncomfortable. Okay, so uncomfortable to the point where if you do go cold turkey from heroin, you'll have a really horrible 10 days, but if you get through that, you'll probably be okay. The trouble is, if you're a heroin user who's not used to pain and discomfort because you're taking heroin every day, then 10 days is a long time. And so that's kind of why people stay on it for so many years, because they just can't, it's just too much to bear. So some of the withdrawal symptoms are aches and pains, yawning, runny nose. It's a bit like having the flu, a lot like having the flu. Stomach cramps, diarrhea, really horrible. And like I say, people tend not to be able to face it. The way we treat it, so I've got my slides backwards. The way we treat it at Turning Point is this thing called opioid substitution treatment. Okay, so basically someone is dependent on an opiate, heroin. If you're dependent on one opioid, then you're dependent on any opioid. So what we do is we give them something else. We tend to use methadone. So methadone is an opiate, an opioid. Opiates come from the opium poppy. Opioids act on the opioid receptors. So all opiates are opioids, but not all opioids are opiates, if that makes sense. So we give people this stuff. So people are still dependent on opioids. They will still withdraw if they come off it, but we've just switched it. So people stop using heroin. We give them methadone. And the idea is, well, methadone is free. It's pure, it's stable, it's predictable. You don't have to interact with drug dealers. You don't have to rob old ladies to fund your habit. You're still dependent, but you're dependent in a much safer, more predictable way. So at Turning Point, we give heroin users methadone, with the idea being that they can then get on with their lives. Yeah. So some people say, well, with Turning Point, what's your success rate like? How successful are you? And the answer is, well, it depends on what you mean by success. So if you mean you've got someone completely off drugs and alcohol, then our success rates are quite modest. But if you say, oh, well, if you define success by the person is still alive, or the person hasn't been in trouble with the law for 2 years, or the person's working again, the person's holding a job down, holding a tenancy down, then actually our success rates go up and up. And it's things like methadone, things like the needle exchange program that help with that. I've just seen a comment pop up. Natalie, what withdrawal signs should we look for in newborns when the mother has been dependent? Okay, very good question. So if expectant mothers who are dependent on, well, using any drug really, whether it's alcohol or heroin or crack, which we'll talk about in a slide or two, but particularly anything that is dependence forming, alcohol or heroin, we need to get them in treatment straight away. So they should be in treatment with Turning Point ideally. There are substance misuse specialist midwives. There's a team of them in Leicester. If you are an expectant mother who has a dependence, one of these teams should be your midwife, okay? And they will help people through the process. If you get a mother who is, let's say they're in the 3rd trimester and they are dependent on heroin, you might think, well, we need to get them off. We need to you know, wean them off, methadone, whatever, wean them off, get them down to 0 before baby's born. That's not always the safest thing to do. Actually, it might be more about stability. So you know, opioids do cross the placenta. So if mother is dependent, then baby is dependent. And it's certainly the case, quite frightening to behold, that babies are born having seizures, you know, having the withdrawal profile. It's seldom dangerous and can be kind of treated. You know, if you kind of like look after a baby, what you wouldn't give a baby methadone, but what you would do is treat the withdrawal symptomatically. So like if you know, if a baby is fitting, you'd give them a medication for fitting. Not that seizures are a side effect of opiate withdrawal, that's more alcohol. But if you can treat the symptoms of neonate withdrawal, then actually they can get better in a week or two. Baby's not going to remember. You know, they're kind of looked after. It's scarier to look at than it is to go through. But if you're looking for like in newborns, really, mum needs to be in with one of the specialist substance misuse specialist midwives. Okay, where were we? Let's talk about overdose. This is a big one, heroin overdose. So heroin is a central nervous system depressant. Depressant, not that it makes you miserable, although it'll do that as well, but depressant in that it slows everything down. So it'll slow your breathing down, it'll slow your heart rate down. Now the danger is if you take too much of this stuff, your breathing slows down to the point where it stops, you know, and then you're dead. So some of the dangers are like if you take other things that do the same thing, so alcohol will slow your breathing and your heart rate down as well. Benzodiazepines, things like Valium, diazepam, they'll slow your breathing and your heart rate down. So if you take too much of these things, that's when the risk of fatal overdose gets higher. Heroin is often also injected with you mix it with crack cocaine, which is a stimulant, because you want the euphoria of the heroin and you want the euphoria of crack, which we'll talk about. You want the best of both worlds, but what happens is the crack wears off first, and then your heart rate slows down, and then you can go into heroin overdose. Purity is really variable. I think the purity of heroin, if you buy a gram of heroin from your local street dealer, you're not getting a gram of heroin, you're probably getting about 0.4 of a gram of heroin, and the rest could be whatever they cut it with, paracetamol, Valium, you know, bulking agent. But sometimes you might get lucky, or you might have a bad batch and the purity will shoot up, and then you take the same amount that you're used to taking, but because gram for gram it's stronger, you put yourself in a risk of overdose. So one of the we're not going to talk about the law today. We're not going to talk about my feelings about drug laws, but one of the things about having a prohibition on all drugs is you hand over the manufacture and distribution to the black market, and then you can't vouch for things like purity or quality control. So a lot of the problems that come from drug use come from those impurities, and you don't know what you're buying really. One of the advantages of methadone, which is pharmaceutical grade, is you do know what you're getting. It's much more predictable. There are other opioids out there, things like fentanyl, which is what they give people as an epidural. People giving birth is a strong opioid, and sometimes you get heroin mixed with that stuff, and you can overdose that way. So real risk opioid overdose is very common. So what can we do about it other than education, which we do a lot of? We give out this stuff, naloxone. Have I got one here? So naloxone is that yellow box there. We're trying to get as much of this stuff out there as possible. This is the opioid overdose reversal. It's like the antidote, okay? And the way it works is the naloxone molecules go to those opioid receptors on your brain where the heroin molecules are, and they flick them off, and actually pushes you straight into opioid withdrawal. So you go from overdose into withdrawal, but it saves lives. So it's a pre-filled syringe, and you probably can't see from this picture, but there's like 5 shots in there. And what you do is someone's overdosing, you stick it in a muscle like the thigh or your buttock, and you give a shot of this, and someone should come out of it. You still need to call 999 because the risk is they might go back into overdose. So what we say to people, if you're using heroin, especially if you're injecting, don't do it alone. so that if you do go into overdose, you've got a friend there who can bring you out of it. But yeah, we're trying to hand this stuff all out as far as we can. We do it in the hospital. I think the police are giving it out now, and we do it at Turning Point, and lots of chemists have this stuff. We want it. It certainly saves lives, so we're trying to get as much of this naloxone stuff out there as possible. Okay, so that's heroin. Yeah, I should say with methadone, the idea is methadone's not a fantastic drug. You're still dependent on something. But it's like the lesser of two evils. Again, the textbook way of doing it is you get up to a dose of methadone, which holds your dependence, however much heroin you're using a day, and then you wean yourself off the methadone, like with alcohol. You wean yourself down to zero. Again, easier said than done, but that's kind of the textbook way of doing it. So there are other things available. We use another drug called buprenorphine, which, as well as being an opioid, is like a blocker. So if you did have heroin as well as the buprenorphine, you wouldn't get the effect. So that there's a few options that we can do. Turning Point have a clinical team. We've got a consultant, doctors, nurses, prescribers who are experts on all this and do this kind of stuff. Okay, more to be said about heroin, but we don't have the time, unfortunately. Let's move on. Let's talk about stimulants. So here are some of the common stimulants out there: cocaine, crack, which is a form of cocaine, MDMA, ecstasy, amphetamines, novel psychoactive substances previously known as legal highs, but they're not legal anymore. Kind of like a new wave of drugs that came out about 10 years ago now, actually. Things like mephedrone, meow meow, the papers called it at the time. Not out there so much these days, but there's certainly some of the stimulants out there. So, generally speaking, there are three kinds of drugs. And it's very vague because there's more exceptions than actually drugs that obey the rule. But three kinds of drugs: depressants, stimulants, and hallucinogens. So uppers, downers, and psychedelics. I'm not going to talk about psychedelics because they tend not to cause people problems, but uppers and downers. So things that relax you. These are the depressants, things that relax you, things that calm you down, things that take away your anxiety. And that'll be your heroin, that'll be your alcohol, that'll be your diazepam. And then there's stimulants, things that energize you, things that give you confidence, things that make you feel good, give you power and energy. And each of these kind of drugs come with their own euphoria, and there's like an appeal to them that people are going for. So when people take stimulants, that it's that energy, that power, that confidence, that euphoria that people are looking for. So cocaine, kind of the most famous one. Again, it was originally a medicine. Cocaine is, again, 100+ years old. So it's like a white powder, comes from the coca leaves in South America. It was used as a local anesthetic. Like if you inject it just under the skin, it will numb that part of your skin. If you watch the movies and they do a drug deal and you see one of them dab his finger in it and rub it on his gums, he's looking for his gums to go numb, and that's how you know it's cocaine. Trouble is, other things will do that, like baby teething powder will do that you can buy over the counter at Boots. And oftentimes, if I'm a cocaine drug dealer, I'll mix it with baby powder from the chemist because people will think it's cocaine and I'll make a bit more money, which certainly happens. So again, like with heroin or like with any black market drug, the purity is unpredictable. It's going to be anywhere from 15 to 85% actual cocaine, or when gram for gram when you buy it. There tends to be like in the market, there tends to be tiers of quality. So you can get like £100 bag of cocaine and then a £200 bag of cocaine, and the idea is the £200 one is purer. But of course, you don't know that if you're buying. It might be your dealer says, yes, well, this is the good stuff. This is £200 a bag, but they might just be conning you. Might be trying to make money. So it gives people energy, gives people power. The big problem with cocaine, in fact, the big problem with all of these stimulants is the pressure they put on your cardiovascular system. So that is, they increase your heart rate and they increase your blood pressure. They do that by narrowing all your veins and arteries. It's called vasoconstriction. Now, if you squeeze a tube there's the risk of that tube popping. All right. Now, if one of the blood vessels in your brain pops, that's called a stroke. All right. Now, I've been working at the Royal Infirmary for about 5 years now, and in that time, there've been a good half dozen people in their 20s and 30s who've died from strokes from using cocaine. Right? And that's not always chronic, heavy cocaine use. A couple of those people, there was like one-off cocaine use. Increases blood pressure, blood vessel in the brain pops, game over. Tends to be snorted now, and it can caught it through your nose, through like a straw or like a rolled up banknote, if you want to be like the movies. Again, because of the narrowing of the blood vessels, actually, if you continually put it in your nose, the tiny blood vessels in your nose get narrowed to the point where blood can't get through it, and therefore you can't get oxygen to that tissue in your nose. Now, if you deprive any part of your body of oxygen, that part of your body dies. So you see some people they kind of like burn through the septum in between their nose. So that's some of the risks you can put yourself at. Cocaine is often taken with alcohol, kind of goes hand in hand. Like if people are out drinking, they get to the point that they're drunk, they can't take anymore. Well, if you have a line of cocaine, it'll sober you right up so you can carry on drinking. But this puts even more pressure on your liver. And actually, cocaine and alcohol react in your liver to create a third drug called cocaethylene, which is actually more toxic to your liver than either cocaine or alcohol on their own. So that's cocaine. That's some of the risks involved. So let's talk about crack, which, like I say, is a form of cocaine. Thing about powder cocaine, you can't smoke it. If you try and light powder cocaine, it'll just burn. But people want to be able to smoke it. People want to be able to inject it. So what they do is you take powder cocaine. I think it's as simple as mixing it with bicarbonate of soda, baking powder. You mix it with that and water, and it will crystallize into crack. And then what you can do, you can smoke it, you can vaporize it. Now, if you do that, it gets into your system much quicker than if you're like just inhaling the powder and it going through the tissue in the back of your nose. If you're inhaling it directly into your lungs, it will hit you harder, and you get that rush of energy and euphoria much more quickly, and therefore it is much more addictive, crack. Okay, because that feeling of euphoria comes on so much quicker. And kind of like the unwritten rule is that crack is the most addictive substance out there because of the speed and the intensity of everything that comes on. It's hard for people to get over crack. The dangers of doing it chronically are the same dangers as cocaine that we've talked about, blood pressure in your heart and everything. Other risks come with it too. There's a thing called crack lung. It's like the alveoli of your lungs, that part of your lungs that turns oxygen in the air into oxygen in your blood. They can get sort of damaged, and that's permanent, as I understand. And you can see it on an X-ray as like a shadow on your lung. So people get breathing difficulties from doing it too much. Dangers come from using crack and heroin together. That's called a snowball. A lot of people who are daily heroin users are also daily crack users. And I think that probably comes from originally is that drug dealers who sell heroin also sell crack. So if you go to your drug dealer for some heroin, they'll say, oh, do you want some of this crack as well? And then before you know it, you've got someone who's addicted to both. All right. In my experience, people in that situation tend to see heroin as the problem. Oh, I need to get off heroin, I need to get off heroin, but I don't want to get off crack because it's so moreish, it's so nice. However, if you spend 3 days on crack, at some point you want to get some sleep, you want to come down, and so people use a depressant drug like heroin to come down. Okay, so but if you're trying to give up that thing that helps you relax from the crack, you know, it makes it harder to get off the heroin if you carry on using crack. That's what I've noticed. Very hard when people are using both to get off either. But you know, this is and again, it's a harm reduction approach in that situation, trying to keep people safe for as long as possible until they're ready and have those skills in place to try and overcome those addictions. I should say with cocaine and crack, they are not dependent forming. So they're addictive, sure, but they're unlike alcohol, unlike heroin, you can't get physically dependent on them, and therefore there's no withdrawal from them when you come off them. All right. It's so, and in a sense that makes it harder because all the work you have to do is psychological around the addiction. There's no kind of like chemical crutch like alcohol or like a detox or like methadone. There's nothing like that for crack. You just kind of have to do the psychological work. So crack is pretty hard to come off, but certainly not impossible. Other stimulants, MDMA, ecstasy. Let's talk about this. So it's the same stuff. MDMA, methylene dioxymethamphetamine. I think what MDMA stands for. You press that into a pill form and it's ecstasy. Okay. I think the prevalence of whether people use this crystal MDMA or the pills, I think 50-50, give or take, people using either. So what is it? It's like a party drug. So if you take ecstasy, it tends to be used in like a social clubbing environment where there's music, where there's friends, and it creates, as well as a sense of, you know, it's a stimulant, so as well as a sense of energy and euphoria, it kind of gives you a sense of empathy and understanding, and music, it kind of let you connect with music a lot more readily. It's not called ecstasy without reason. Where the kind of euphoria it gives you is you tend not to come across in life without chemical means. So people do tend to use this stuff like in a social context. Not really addictive form, and very few people use this stuff day in, day out. I think it would just wear you out too much. But so the dangers with this stuff tends to be from those binge episodes when people are, you know, using it heavily at the weekend. Biggest problem with ecstasy, the tablets, is they're too strong. Like one tablet is probably way more than you need. When ecstasy first came out in like the late 80s, early 90s with like the acid house rave scene, I think one ecstasy tablet was about 80 milligrams of MDMA in it. Nowadays, it's something like 250 milligrams per tablet, way more than you need. I think the reason they get stronger over time is like market forces over time. One dealer wants a stronger pill than the next dealer, and everything just gets stronger over time. That's happened with cannabis as well. The problem with MDMA, ecstasy, it can kill you. There's a few different ways it can kill you. One is you just straight up take too much. So this is a stimulant. This will make your heart rate go through the roof. You won't be able to cool down. Your temperature will go up. So you can just take too much where it just blows your system out, and it can kill you that way. Similar to that, a way it can kill you is bearing in mind that you might have this in a hot nightclub where you're dancing and dancing, you're dancing, you just overheat. You forget to drink, you forget that you need to sit down and chill out for a bit because you've got so much energy. So your temperature can go up, and you can have a seizure, and you can kill you that way. Probably the most dangerous way that it can kill you actually is it's connected to that. People in those hot environments actually recognize that they need to drink, cool down, and actually they drink too much. So really common is people, well, not too common, but people out, one of the most common forms of death from ecstasy is people drinking too much water. And then they get something called hyponatremia, which means low sodium in your blood. You've sweated out all this salt, you're drinking water, and you're not replacing that salt, so you get hyponatremic, low sodium. I don't know if you guys remember Leah Betts from the 90s. She was like the poster girl for the dangers of ecstasy overdoses. She took ecstasy on her 18th birthday, and that happened to her. There's a picture of her sort of plugged into all these machines, and she died from hyponatremia. So what we say, like, if you're going to be out using this stuff, only have a bit. You won't need one tablet. Start with a quarter, or if you're on the powder crystal, just have a dab, and then wait 45 minutes, an hour. It can take that long to kick in. Some of the dangers is people have some, wait 20 minutes and say, well, it's not worked, so they have more. And then the first lot kicks in and it's strong, and then they know that the second lot is coming as well. So it's important, really important to start low and pace yourself. And we say to people, do stay hydrated and cool down, but don't overdo it. So a pint of water an hour, we might say. Even better if you use like the isotonic drinks that have those electrolytes, that sodium that you're at risk of missing out on. We do say avoid alcohol, but not always realistic, because like if it is in a social clubbing environment, that's kind of go hand in hand with alcohol. Okay, so that's MDMA, ecstasy. All right, moving on. Cannabis. I mean, working in drug services, when you're working with people who, you know, take heroin and they take crack and they take this and that, a huge proportion of those people smoke cannabis as well. And often, sometimes it feels like the case is like, well, yes, you smoke cannabis, but we've got bigger fish to fry. Let's talk about your crack use. And if at the end of the day you get off this, you get off that, if you're still smoking cannabis, you know, it's not too bad. But cannabis certainly can cause people problems. Rarely fatally, or if ever. I don't think that there's any recorded deaths of cannabis. It tends not to kill you. One of the main physical dangers of cannabis is actually the tobacco it's mixed with. You know, if you're rolling a cannabis joint, you put a certain amount of tobacco in there. Unlike a cigarette, it doesn't have a filter on it. You know, it's just, there's no filter on the end of that. And if people are doing this 5-10 times a day, they're taking in a lot of tar, a lot of smoke, and often that's what causes respiratory problems when people sort of smoke this stuff chronically. With cannabis, it's so strong, and again, it's like the market forces over time. It just gets stronger. THC, the active ingredient in cannabis, it's got more and more intense as the years have gone on. So it's this potent super skunk, it's called, that tends to be out there at the moment. So you know, it's really sort of too much to be enjoyable, really, and it can cause like. Cannabis can't cause psychiatric problems. It can cause like paranoia and kind of low level problems with your mental health. But it you know, the myth is that it causes schizophrenia. It doesn't. However, if you've got any latent underlying psychoses or psychiatric problems, then cannabis can bring that out. So there is a risk of bringing those kind of things out of you if they're in you already. Yeah. So what we say is like, try and have less. Try and cut. It may be that, like we see in America, who've recently decriminalized cannabis, what that does is it opens the market up, and you can say, well, I don't want the strong stuff. I want this, or I want a cookie with cannabis in it. Something like that. If that happens in the UK, we're probably not in the next few years, but I think it's probably inevitable. Then the market will probably open up, and we'd say, you know, have something less strong. To my mind, the biggest problem with cannabis is what it does to your motivation. So we see people who wake up in the morning, the first thing they do is roll a joint, and that's the whole day gone. And they just spend their days smoking, playing Xbox, watching Netflix. And people can do this for years after years after years, and they look back and say, where did my 20s go? You know, that was what I did for a decade. So I think that's the biggest problem with cannabis. So we'd say to people, look, if you're going to smoke, have it in the evening. Make sure you've got your day out of the way first, and you know, 1 and 2 in the evening. But yeah, cannabis tends to be forgotten about because we're dealing with the bigger things, but it can definitely cause problems for people. Not nearly as much though as this stuff, spice/mamba. So the zombie drug, as the Leicester Mercury calls it. You might have seen pictures of people standing in the street with their head down, swaying side to side. Most of the country calls it spice. In Leicester, we call it mamba, but it's kind of the same stuff. You can sort of think of it as synthetic cannabis, but that's not really the case. The only similarity it has with cannabis is it works on the same parts of your brain, which is the cannabinoid receptors. There, the similarity with cannabis ends. So this stuff was it was originally part of this wave of legal highs back 10-15 years ago. So people would say, look, we've got this brand new chemical that we know acts on the cannabinoid receptors, but it's legal because there's no legislation that specifically spells out that it isn't legal. And so people would sell this stuff in head shops, you know, like the Very Bizarre used to sell it. Right? Anyone that sells like Joss sticks would sell this kind of stuff, and it was legal. And Now this stuff is a crystal, it's a crystalline powder, but it tends to be sprinkled on a smokable plant matter like sage, so it looks like cannabis, and that's kind of like how people smoke it. So it was legal. What happened is the first wave of this chemical came out. People were smoking it. The government then banned it. But then what these underground chemists did is they just tweaked the molecule slightly. They changed one atom in the molecule. Still pretty much the same stuff, still works on the cannabinoid receptors, but is legal because there's no piece of legislation that says otherwise. And this happened again and again and again, and the law was always playing catch up. It was like whack-a-mole. They were banning these things as they came out. Up until the 2016 Psychoactive Substances Act, which banned any future chemicals. It said, if you make a chemical which has a psychoactive effect, that's the government's definition of a drug, whether now or in the future, that thing is illegal. And that stopped these waves of brand new chemicals coming out. However, by then the genie was out of the bottle. And this stuff, Spice Mamba, it's not one drug, it's any one of like 24 different things that are out there that all work on the same part of the brain. And this stuff is nasty. To start with, they're brand new drugs like heroin, cocaine, cannabis, alcohol. This stuff's been around centuries. We know what this stuff does. This Mamba stuff is brand new. We don't know what it does to people other than what they're presenting us with. So here's what we see it doing. It can kill you. You can have one puff, and in extreme cases, it can give you a seizure, and it can kill you acutely. Part of the reason that is because it's a crystal that you sprinkle. There's a chance that you can get a particularly hot bit, so you get very concentrated bit that you have with one puff, and it can like overdose you that way. So bearing in mind, cannabis doesn't kill you. This stuff can. It seems to be dependence forming. So you smoke enough of it, you get physically dependent, and you get a withdrawal syndrome, which seems to be vaguely similar to opioid withdrawal syndrome, like the flu-like symptoms, stomach cramps, diarrhea. We see a lot of gastric problems with this stuff. People getting really bad stomachs. The depression that seems to come along with Mamba withdrawal, people talk about really suicidal kind of depression coming along with it. So I'm hesitant to say that any drug is all bad. Pretty much every drug has good things about it, and you can understand why people take it. This stuff, not so much. Tends to be big in the homeless population. It's cheaper than cannabis. It's more readily available. People smoke it in prison, and the reason for that is it doesn't smell like cannabis. It has a very potent, recognizable smell. This stuff doesn't, so you can kind of get it under the radar. And also because it isn't one drug, it's like one of 24 drugs. It's not easy to test for because you'd have to do 25 different tests. So people are going to get it under the radar that way. But we're seeing huge problems with this kind of stuff. Again, in hospital, in the A&E department, we see a lot of people coming in worse for wear on this stuff. Often you just kind of keep it, like if someone has too much of this and it'll knock them out on the floor, wait 6 hours, they'll be up again and they kind of walk out. So yeah, it's interesting, nasty stuff. Pretty prevalent in Leicester. Like I say, mainly in the kind of the homeless community. Okay, spot. I'm just looking at the time. We've got about 10 minutes left and a few more of these to get through. So let's get on with it. Well, I've mentioned this stuff, benzodiazepines, benzos, which you might never have heard of. If you're a hardened drug and alcohol user, you'll know all about benzos. So again, this is a medicine. It's an anti-anxiety drug that can be prescribed by your GP. So the most famous one is Valium, diazepam, but there are others. Xanax is a big one at the moment because American rappers rap on about Xanax, and it's kind of crossed the Atlantic, and young people, students tend to use Xanax. Although we don't know it is Xanax, it might be something black market that's been cooked up in a lab, because Xanax, or alprazolam to give it its chemical name, isn't licensed for any kind of use in the UK as a medicine. So for like short-term anxiety problems, these things can be prescribed. The problem is they're very Moorish because they take away anxiety. They make you feel very zen. That can be appealing. So that's why people like this stuff. And if you're like a crack user, or like where you're up and down with alcohol, your mental health pulls you in different extremes, it's quite appealing having a pill that can make you feel all zen and calm. That's wherein the addictive property of this stuff lies. But really dangerous to be hooked on this stuff. For a start, it's dependence forming, just like alcohol, because it works on the same neuroreceptors as alcohol. So the withdrawal profile of these benzos is the same as alcohol. It can be fatal. Yeah. So if someone's on this stuff heavily, don't stop suddenly. It's about weaning down. They can increase the risk of overdose. For like, you know, people might take it with heroin. So you mix this with anything else that slows your breathing and your heart rate down, you're at the risk of having that more fatal overdose. What else to say about this stuff? Yeah, it's what we use in alcohol detoxes, because it's cross tolerant with alcohol. If you're dependent on alcohol, you switch it for this stuff, and you don't withdraw because that dependence is being satisfied in pill form. But yeah, not good to be on this stuff long term. If you're on this stuff chronically, it takes something like 10 years off your life. It's like as your life goes on, it's like your IQ just ticks down as the months go on this stuff. So you don't want to be on this stuff too long. But really Moorish, and people love it. And people will, because you can prescribe it. Turning Point don't prescribe it because we know how addictive it is, but GPs and at the hospital, we get people banging their fist on the desk saying, give me some diazepam, give me some diazepam, because it makes all your worry go away, but it can be really dangerous to just hand it out. Okay. Right. Again, just looking at the time. Let's move on. But if you do have any questions at the end, we'll certainly have time for that. Okay, then there's this stuff, GHB, which stands for gamma hydroxybutyrate, which metabolizes into GBL, which I don't know the name of. Now, this is you might not have heard of this stuff. You can buy it over the counter as like a chrome alloy cleaner for cleaning making your car hubcaps nice and shiny. It's legal for that purpose, but illegal for any other. It's a liquid. And people drink it. It's a relaxant. It makes you feel relaxed. It makes you feel euphoric. It is, like I said, so this slide was meant for some nurses at the hospital. So some of these might not make any sense to you. Tends to be big on the chemsex scene. You might be aware of this. Chemsex is kind of like the scene where men who have sex with men use a certain combination of drugs to make sex parties last 2, 3, 4 days. Along with certain stimulants like crystal meth, which we haven't really talked about, mephedrone, which is one of these old stimulant legal highs, along with this stuff, which is known on the streets as G, to make some. A lot of times you have a stimulant and then you have a depressant, so to make these things last longer. But the problem with this stuff is it's addictive, it's dependence forming. So, and it's just like alcohol. However, because this stuff, you take it in very small quantities. And if you get dependent on it, it's not like you're dependent on 10 cans of beer. It's like you're dependent on 10 mils of this stuff. So if you're trying to do a reduction, very hard, because we're talking about splitting it by fractions of a milliliter. But you know, that's how you do it. You need to wean off it. But the withdrawals from it, they seem, again, puts you at the risk of seizures and death, but it tends to come on quicker. I've got a message about my recording. 5 minutes left. That's fine. So yeah, so this stuff, addictive like alcohol, dependence forming like alcohol. We'd encourage people to get people into treatment. It can cause lots of problems. Actually, it's one of those date rape drugs as well. There was a serial killer a couple of years ago in London. I think he killed young men and dumped them in a graveyard, I think, churchyard. This is how he killed them. He'd overdosed them on this stuff. Yeah. So pretty nasty. Okay, moving on. Right, okay, this is the last one of these I'm going to cover, and then we'll talk about some of the support that's available. Okay, so about steroids quick. Now, I'm no expert on this. I've got a couple of colleagues at Turning Point who are experts on these things, and if you guys want a bespoke session about steroids and performance enhancing drugs, I'm sure they'd help you out. So we get a lot of this, people who want to build muscle mass, people who are really into like exercises and gyms, people want to you know, they want to build their bodies up, might take these performance enhancing drugs, which tend to be hormones, testosterone or variations thereof, tend to be diverted often from veterinary sources, so it's meant for animals. Yeah. And what you do is you inject this stuff into your muscles, and you take it in cycles. Like, I don't know exactly how it works, but I think, say you take it every day for a couple of weeks, and then you leave it a couple of weeks, and then you do it again. Yeah. So it's like a cycle, on and off, on and off. So some of the risks of doing that, first of all, you're injecting, and just like injecting heroin, you put yourself at a lot of the risks in terms of like tissue damage of injecting something that regularly. Because it's like a hormone, it can cause problems with aggression, paranoia, irritability. So it comes along with like mental health issues as well. Can cause hormonal imbalances, like if you do one thing to one hormone, that might have a knock-on effect as your body tries to compensate with another hormone. It could be illicit. You don't know that, even though it comes in a nice bottle with the name on it, you don't 100% know that that's what's in there. So it could be counterfeit, could be impure. So what we do at our needle exchange, we educate people around this stuff. And if people are struggling with it and want to get into treatment, then they can. Okay, this is good. Time-wise, we're doing well. That's it. If I didn't talk so quick, we'd need fewer slides. Okay, right, so that's drugs. There will be a chance for questions at the end. So we talked about drugs, we talked about alcohol. If you've got a problem with any of this, what can you do about it? What support is available? Well, Turning Point is the commissioned drug and alcohol agency in Leicester, Leicestershire, Rutland. Okay, so if you go to your GP anywhere in the county and say, I've got a drug or alcohol problem, Turning Point is the service that your GP should refer you to. Okay, the way we're actually up for recommissioning at the moment, so hopefully Turning Point get it again, but it's certainly a possibility that next year it could be a different provider, but it'll probably be Turning Point. So our main base is in Leicester, but we see people, we've got offices in Loughborough, Colville, we see people out in the county, Melton, Market Harborough, Lutterworth, Oakham. We've got adult team, we've got young people's team, we've got a prison team, we've got a criminal justice team, we've got the hospital team, which I'm on. So we're kind of everywhere. So I don't know how many service users we have. My guess is around the 5,000 mark. So that's people in for drugs and alcohol. So we see an awful lot of people. Give or take, there's 200 plus people work for Turning Point in the county. So we're quite a big outfit, quite a big operation. If somebody has a drug or alcohol problem and they want to get help from Turning Point, here's what they can expect. First of all, they'll be allocated a recovery worker. So that's somebody like me. I'm a recovery worker. They have to call us that because they'd have to pay us more if they called us a drug and alcohol counsellor. But recovery workers, drug or alcohol counsellors. So they would get allocated a recovery worker who'd be their main contact, and they'd put together a care plan with that person of how best Turning Point can support them. Pre-pandemic, although ideally post-pandemic as well, the main thrust of the work at Turning Point is a group work program, and that's cognitive behavioral approach. It's all the work about identifying your triggers and developing coping strategies, about understanding what makes your addiction tick, how you talk to yourself in your mind, and what you can do about it. Cognitive behavioral approach is what we do. It's about preventing a relapse. If you've got a drug problem, there's always two jobs. One is to get off it, and the harder job is staying off it into the future. So it's about sort of preparing yourself for a future without your drug or alcohol of choice. Like I mentioned earlier, we have a clinical team, doctors, nurses, prescribers. The main thing they do is prescribe methadone, but they're also experts in alcohol and all other bits and pieces. We've got nurses who can do like liver tests and give vitamins and all this kind of stuff. We've got needle exchange, like I mentioned earlier, so that's giving people all the stuff they need to, as safely as possible, inject, which, like I say, is demonstrably better for public health. Turning Point hold the keys for detoxes and rehabs. again, like at the hospital, we'll get people turning up at the front desk saying, I need a detox right now, detox me, detox me. Like, no, you need to go through Turning Point. If we detox you right now, you don't learn anything about how to cope, you'll relapse straight away. Go to Turning Point, do it properly, you're more likely to succeed. Turning Point also do rehab referrals. People get confused between detox and rehab. Rehab is somewhere you go to live residentially for 3 months, usually, having already been detoxed. And in that rehab, you then learn how to live, how to cope with life without your drug of choice. So that's rehab, and that's something that we offer. We've got the peer mentor program. So the peer mentors are people who've been there, done that, got the t-shirt, they've overcome their own addictions. We've trained them up to volunteer with us. So then there's people coming in at the start of the process. I've got like role models saying, oh, this person overcome their problems, I can do it too. And oftentimes when a job comes up as a recovery worker, it's the peer mentors who get those jobs. So there are people who do my equivalent job who know what they're talking about because they've been through it themselves, rather than someone like me who's just been to university and studied all this kind of stuff. People like know what they're talking about from life experience. We do bloodborne virus testing. We've got good links with the liver clinic at the Royal. So anyone who does test positive for Hep C, for example, we can plug them straight into the support with that. Again, more pre-pandemic, but we're going to be doing it more post-pandemic, is all the wraparound stuff. Like, rather than use drugs or alcohol to relax, how can you relax in a more positive way? So things like mindfulness, meditation, yoga, art classes, music classes, that kind of thing. Okay, so that's what people can expect if you refer them into Turning Point. And so please refer. Like, anyone can refer. People can refer themselves. GPs can refer. You as professionals can refer people in, with their consent. We try and make it as easy as possible for people to get engaged. Probably the best way of doing it is online, rather than spell out the URL. If you just Google Turning Point Leicester professionals, you'll see that page come up, and you click complete the referral form, and you just fill in the person's details, as brief as you can, what their drug or alcohol problem is, and we'll take it from there. Okay. All right, so that's it for the presentation. Does anybody have any questions? Only 3 minutes out of time. Let's keep going. We've covered a lot. Like, I know it's a lot of information, but you have to squeeze it down in such a short period of time. Any burning questions about anything?
Thanks for that, Drew. Just in terms of an individual self-referring, then, is there like a drop-in that somebody can go into Turning Point themselves and self-refer, make a self-referral for help?
Because of COVID, you can't just walk in.
Yeah.
Our base is in Eldon Street in the town. Yep, it could be that you could just walk in and say, I've got a problem, please help, and they take it from there. Best way again is online or through our phone number. People, that's the best way for people to self-refer.
Yeah.
Yeah. But because we're like a public health agency, we're being extra careful with COVID. Like we're still all wearing masks in the office. We're still doing social distancing. I'm working from home at the moment, so we're still playing it as carefully as possible.
Yeah.
For young people, what age do you accept referrals from? I forget if it's 11 or 12. I know at the hospital we'll see like in children's A&E, we get young people coming there, sometimes having taken whatever, and there's no bottom age limit. But our young person's team, I think it's 11 or 12 we take people from, and that goes up to 25.
Hi, Drew. Can I ask is it sort of a specific office that you support young people in? Because I work with 16 to 17-year-olds. So if I was to make a referral, I appreciate you're not open at the moment. Is it just sort of phone calls at the moment?
I'm not 100% what the young person's team is doing. So the young person's team office is on Granby Street in the town. So that's separate from the adult office, because you don't want adults and young people mixing, because there's opportunities for like grooming and getting people into trouble. I think it's mostly phone work at the moment, but if any one of our teams is doing outreach and face-to-face stuff, it will be the young person's team, especially now schools are open. So yeah, I'm not quite sure what the young people's team are doing, but for the most part, it's on the phone.
Okay, thank you.
I get it whenever there's like safeguarding concerns, especially where children are involved. We do go the extra mile. So I imagine that there probably is a lot of face-to-face stuff going on right now.
Thank you.
Any more questions?
I just wanted to say thank you, Drew. It was really informative. I'm afraid I felt a little bit uncomfortable in the first half about alcohol, and perhaps other people did as well. But I think that you need to look at yourself sometimes as well in these when we're talking about our drug use, because alcohol is a drug. Yeah. So thanks very much.
14 units is not a lot.
No,
Very,
I was counting them up in my head, and yeah. Food for thought.
Yeah. Well, thank you very much for having me. I've enjoyed it.
Lovely. Could I ask people to fill in the evaluation that I'm going to post again? You don't have to stay on the line to do it, but if you just open the link, which I'm going to post again, if I can find it. And then you can fill it in. It is a pre and post type of evaluation. I have to go this way. Sorry, I'm having to find the link again because I can't. Everybody's writing, which is great, saying thank you.
My pleasure. Could we stop recording? Yes, I'll stop recording.